Hello, my name is Anna Hetmansberger, and I am a first-year student in Eastern Kentucky University's Rural Health Family Nurse Practitioner program. At the beginning of NSC 892 Nursing Research Project, we were challenged to identify a healthcare problem that is of interest to us and propose an interventional study pilot that could improve this area of healthcare. Working in a neurointensive care unit, I chose to explore aspiration pneumonia among stroke patients with dysphagia because this is a prevalent problem among this patient population. My proposed interventional project is a pilot study using an interdisciplinary transitional dysphagia education program that focuses on multiple non-pharmacological interventions for self-care and its effect on reducing 30-day rehospitalization rates. Aspiration pneumonia refers to a lower respiratory tract infection caused primarily by the inhalation of oral pharyngeal secretions colonized with pathogenic bacteria. It is the second most common infection among hospitalized patients and has the highest attributable mortality of all medical problems following stroke. It includes more than 200,000 cases and 15,000 deaths per year in the U.S. alone. In fact, the incidence of developing aspiration pneumonia triples among adult hospitalized stroke patients after discharge. Rehospitalizations due to aspiration pneumonia are costly, always potentially harmful, and often avoidable. Review of the literature included 8 publications which examine non-pharmacological interventions to reduce the risk of aspiration pneumonia among this patient population. Synthesis of the data revealed that non-pharmacological interventions may improve health outcomes for stroke patients with dysphagia by reducing the risk of aspiration pneumonia. Synthesis of the data also revealed that non-pharmacological interventions are easily implemented, cost-effective, and acceptable to a majority of patients with a minimal burden. My proposed project will take place at Lake Cumberland Regional Hospital, Somerset, Kentucky, on their neurocritical care and neuromed-surg units. This location was chosen because they are a stroke-certified hospital and predominantly serve the rural public. The time frame will last approximately 6 months, allotting enough time to reach a maximum of 30 participants and complete analysis of the data. Phase 1 will begin with the introduction of the process and include educational resources that will lay the groundwork for the remainder of the program. The educational resources will include a stroke care book that all patients admitted with stroke will receive on admission. This book will include stroke pathophysiology and clinical manifestations. They will also receive a non-pharmacological intervention for self-care guidebook that will include all the interventions that will be used in the study, as well as diagrams on how to complete them. Lastly, they will receive a reference letter including names and pictures of the interdisciplinary staff that will be involved in the educational program. Phase 2 will include educational demonstrations with both the patient and their family and/or caregivers. The non-pharmacological interventions will include staying in the upright position during meals and 30 minutes afterwards, oral care that includes manual brushing and 12% chlorhexidine use, chin-down posture during swallowing, as well as swallowing education that includes double swallowing, chewing food on the unaffected side of the mouth, and coughing after each swallow. The demonstrations will be carried out by the primary investigator and/or stroke clinical care coordinator at Lake Cumberland Regional Hospital, as well as other ancillary departments including speech therapy and dietary. The patient's primary nurse will also be involved with reminding and re-educating the patient and family during meal setup each day. Phase 3 will involve analyzing the patient and their family or caregiver's ability to complete the non-pharmacological interventions consistently prior to discharge. This will have to be done with the primary investigator and/or the stroke clinical care coordinator prior to discharge. Phase 4 will involve educating the patient and their family or caregiver regarding signs and symptoms of aspiration pneumonia and clinical manifestations that they will need to look for once they are discharged home. Phase 5 will take place once the patient has been discharged home. This will include telephone calls made by the stroke clinical care coordinator and/or the primary investigator on a weekly basis. Best times would be determined by the patient or family caregiver prior to discharge, and this will take place for 30 days after discharge. During this time, the nurse will identify what's working well and what's not, and provide additional resources for the patient or family. The nurse will also ask questions regarding possible signs and symptoms of aspiration pneumonia and determine if the patient may need further assessment by a primary care provider. A password-protected spreadsheet will be used as a measurement tool to assess pre- and post data. Data will be obtained during weekly follow-ups via telephone with the patient and/or caregiver, and at this time, the patient or caregiver will be asked if the patient has been readmitted to the hospital from which they were discharged or any other hospital. This information will be inserted into the spreadsheet and monitored. Only readmissions due to pneumonia will be counted, and a paired t-test will be used for data analysis of the pre- and post 30-day readmission rates for this patient population. The expected outcome of the interdisciplinary transitional dysphagia education program will be a reduction in rehospitalizations due to aspiration pneumonia within 30 days of discharge by 50% among stroke patients with neurogenic dysphagia. That is the end of this presentation. I would like to thank everyone for their time, and I hope that you have a great rest.